to everyone. This is an amazing day and hour to be with you at the Canadian Cancer Survivorship Research Consortium. It's a very innovative space for exchanging thoughtful and focused research studies. And I have with me today Aishwarya Manish, who has been part of this journey. We want to talk about the enhancing survivorship care and digital health innovations in rural communities through implementation science research approaches. And I hope everyone is able to see our slides that we are sharing on this forum today. I do want to acknowledge Thompson River University campuses on the traditional lands of the Tekton-Shwepnik and Teksik Ulu within Shwepnik Ulu, the traditional unceded territory of the Shwepnik. The region Thompson River University also serves extends into the territories of the Stadlim, Nukals, Nuls, Chilcotin, Dakale, and Selix people. I am Melba de Souza. I'm an associate professor at the School of Nursing and Population Health, and my role is working with cancer research, and my program includes psychosocial, supportive care, early survivorship transitions in care, digital health, and implementation science approaches.
Hello, I'm Aishwarya Manish. I completed my Bachelor of Science in Psychology, and I'm an incoming master's student for public health at the University of British Columbia. I'm a graduate research assistant on this grant.
Thank you, Ash. Today, we want to explain the implementation science framework that was used to identify barriers and facilitators in survivorship care and to assess the role of digital health interventions in enhancing culturally responsive survivorship care and reported outcomes, and also apply these lessons to inform the design, adaptation, and dissemination of early survivorship in diverse rural communities. So we'll take you through the background, the aim, the methods, analysis, discussion, and knowledge translation of this research study. Breast cancer is one of the most frequently diagnosed cancer globally, and it continues to increasingly negatively impact individuals globally. In 2020 alone, approximately 2.3 million cases of female breast cancer were diagnosed, and about 685,000 women lost their lives from the disease. There's an important aspect to this. Following the cancer diagnosis, the access to information resources can improve patients' engagement in care and quality of life. At the same time, information about this illness can also increase the person's confidence in the ability to cope with the effects of the disease. But most often, people rely on health professionals and printed information, though the use of online information has increased over the years. Navigating the healthcare system in Canada is challenging for people due to a few things, and one of them is psychosocial stress, the financial burden, and health consequences they endure during the cancer illness. Cancer survivors, once they're diagnosed, have diverse and varying needs in their supportive care, and they change over their time from the diagnosis to the survivorship. Hence, supportive care should be individualized and prioritized for people to address their biopsychosocial levels. Notably, we can also think of information needs that the person needs and the limitations that they would have due to that could be affected by usability and accessibility in some communities. Example, it's found from research studies the cancer management interventions focus on the improved symptom management and engagement in care, and also on reduced symptom severity. And also sometimes people hesitate to ask questions to their healthcare providers. So there's a varying degree of trust on online resources, which sometimes can be unreliable. There's another study that conducted on nurse navigation approaches that focused on collaborative care, in which nurses addressed both physical and psychological symptoms and refer people to relevant psych specialists so that people can help and engage in their own care. Some of the studies show that cancer inequities exist in Black, Asian, and minority ethnic populations with breast cancer incidence and survivorship challenges that is focused on communication, cultural inclusivity, and access to supportive resources. Prior research have also discussed the vital role that exists in developing an integrated supportive care to bridge the gap between a person's unique and diverse needs and the care that is existing and provided in the healthcare system. These supportive care interventions should be integrated, adaptive, individualized, and grounded in the best evidence and possible ways. And our study is exploring the ways to connect people with breast cancer newly diagnosed with the trusted health information to overcome the barriers that they face with information access. Some of the literature review show early findings from British Columbia. 24% of the women reported not receiving adequate emotional support from their breast cancer treatment phases. And only 50% of the women felt that they received adequate support from health professionals present when they were initially diagnosed. And 20% of the women would have liked to have received more emotional support. These studies in British Columbia in rural communities show that participants reported difficulty understanding, utilizing, and navigating cancer care services, citing a lack of follow-up after treatment, timely coordination after treatment. Our study looks to identify and further evaluate early survivorship approaches for people who may benefit the most from them.
So, what is digital health? Essentially, it's the intersection of technology and healthcare services aimed at enhancing healthcare outcomes. It comes with benefits such as improving health knowledge and self management practices during cancer follow up, but there are potential challenges, which include technical issues, lack of technology knowledge, and data security, which needs to be addressed. Coming to digital navigation in survivorship care, previous research highlights that caregiver navigators using web based tools can connect patients to social support services and foster meaningful discussions. Online navigator tools are found to increase satisfaction and reduce anxiety. Additionally, telemedicine based navigation has proved effective in resource limited settings. Building on these benefits, thoughtful implementation of clinical workflows, enhanced provider education, and attention to access barriers for marginalized communities are essential. Prior research suggests that digital health navigators can address these needs by applying practical and regulatory knowledge to support and train oncology teams, overcome barriers, and ensure timely virtual care across all phases of the cancer journey. So, what do these digital navigators do? Their areas of support include remote monitoring, engagement and literacy, care coordination and virtual navigation, and psychosocial and emotional support.
The main aim of this research study was to design and develop digital health innovations and cancer survivorship that contribute to enhancing knowledge and best practices to help address the gaps in cancer supportive care. The objectives of the study were twofold: what are the barriers and facilitators of accessing cancer survivorship care for people with newly diagnosed breast cancer in British Columbia? And how effective are digital health innovations in enhancing patient engagement in the care and the reported outcomes for people newly diagnosed with breast cancer in British Columbia? The study used a consolidated framework of implementation research phases. So out of setting of the community participatory action, we had the assessment strategies of assessing the needs of the people, their perceptions, lived experiences, and the resources they used, assessing the capacity and readiness for survivorship care. The second was decisions about adaptation of digital health innovations and the possibility of adapting usability and effectiveness of this design. And the third was capacity building strategies of obtaining an explicit buy-in from critical stakeholders and fostering a supportive and community climate, building on the general capacity of the community partners in the community, team recruitment, and pre-innovation team training. The second phase of the implementation research included creating the implementation teams for the consolidated framework for implementation research and developing an implementation plan. The third phase included ongoing implementation support strategies, where we had technical assistance, process evaluation, and supportive feedback mechanism. And the final phase is the knowledge translation, learning from these experiences in the research study. So the implementation science had an outer setting where we had connections and the broader contextual factors of community partnerships. The inner setting included healthcare organizations, the available resources, and implementation climate in rural communities, including the resources, services, and programs. The intervention characteristics of the study included core components of our digital health innovation, the complexity and adaptability of using them in the rural communities. The implementation process consisted of core components of complexity, adaptability of the design that we used in providing the digital health innovations in cancer survivorship and navigation. And individual characteristics included the characteristics of the participants in the study based on the inclusion criteria throughout the study when they were participating in this cancer navigation and reported outcomes. So this used a mixed study approach where we had a user-centered design of developing an intervention group with the pilot in the pilot study of having a professional navigation and utilizing different data collection metrics, both quantitative and qualitative. We had a socio-demographic survey, the cost facet version 2, functional assessment of cancer therapy breast cancer navigation survey, the participant satisfaction with navigation scale, satisfaction with interpersonal relationships, and breast cancer navigation interview. Currently, we are in the very final stage of our intervention study. The randomized control trial centered on a user design process to use a usable application that provides the people with information aligned to their support needs and preferences from the early survivorship care. It was a systematic process that was intended for the particular characteristics of the participants in the study and was tested with interactive health technologies to ensure that these digital health was purposefully used for the intended users. And we had a control group who was using the standard of care, electronic books, and community resources. So the core component of the user design included mobile-based application, open education resource, and interactive web-based education, in addition to telephone calls, interactive teaching learning, and interactive webinars. The most influential components of this design was looking at the usability testing on a small number of potential users in our study with the prototype we used, and also identifying what were usability problems before the application was built. So we had a quality navigator effort and assessments and outcome and impacts to identify user problems and to measure the effectiveness, the learnability, and the error rates of this adaptive recommendations used in the study. Recruitment and retention. We had participants from 100 Mile House, Kamloops, Merritt, Penticton, Okanagan, Vernon, and Revelstoke, and the surrounding rural communities in British Columbia. The main eligibility criteria of the study was based on the objectives, 19 years and older adults, ability to read, understand, and write in English and other languages, a diagnosis of breast cancer at all stages, eligibility for a treatment, post-treatment, people with operable cases of breast cancer, people who are undergoing conserving breast cancer surgeries, people undergoing breast cancer adjuvant, chemotherapy or radiation therapy. Exclusion criteria include people with advanced breast cancer, metastasis to other organs such as the brain, bone, liver, and concurrent malignancies, secondary cancers, young neonates, infants, children less than 19 years, self-reported severe, undiagnosed, untreated psychiatric or cognitive problems that prevented them from giving an informed consent and informed participation.
Here's the digital health innovations model that we have created to address psychosocial issues faced by patients residing in rural BC. The model shows digital innovations that have been developed to address these issues. These digital innovations include the cancer care education web-based application, then cancer care navigation, the breast cancer navigator app, and the Cancer Care Innovation Lab. Today, I will be elaborating on the Cancer Care Navigation web-based application and the Breast Cancer Navigator app. Cancer Care Navigation serves as a bridge between patients, caregivers, healthcare providers, and an array of services and resources available throughout the cancer journey. It is essential for navigators, healthcare providers, and caregivers to meet the needs of patients where they are at. Cancer Care Navigation aims to train professional navigators to efficiently do so. These are the goals of the module. The objectives of cancer survivorship and navigation in British Columbia are to understand implementation factors affecting its use, assess its role in capacity building, mentoring, and support. It aims to enhance quality of life through connection and resource sharing. This is an overview of the Cancer Care Navigation module of contents. It has 7 knowledge hubs. Knowledge Hub 1 is Introduction to Navigation and Survivorship. Knowledge Hub 2 is Information and Education. Then we have Assessment and Strategies. Then Communication and Health Literacy. Knowledge Hub 5 is Psychological and Emotional Distress. Knowledge Hub 6 is Cultural Considerations in Care. And Knowledge Hub 7 talks about survivorship and supportive care. Coming to Knowledge Hub 1, it describes the goals of navigation and survivorship. This section also talks about the domains of needs and phases for patients living with cancer and roles of navigation. Knowledge Hub 2 deals with understanding learning preferences to educate people through a patient-centered approach. Knowledge Hub 3 deals with understanding symptom assessment and utilizing tools such as the BC Cancer Symptom Management Guidelines to do so. In Knowledge Hub 4, we talk about the challenges of health literacy, communication, and education. This section aims to understand the psychological distress patients face and how to assess anxiety and depression. Knowledge Hub 6 highlights ways to effectively provide support through a culturally inclusive lens. Lastly, Knowledge Hub 7 differentiates between different types of psychosocial support. It identifies the role of family in survivorship, emotional and psychosocial support, and psychosocial needs. The section also records challenges for integration and continuity of care. This is the second digital innovation, the Breast Cancer Navigator app. It is a user-friendly platform to support breast cancer patients in Canada. Key features include the AI personalized health plans, symptoms and outcome trackers, and the resource hub. It has 3 separate options, which include the Care Path AI, Personalized Wellness Hub, and Tailored Learning. So in the Care Path AI, it features an AI-powered interactive chat, allowing users to ask personalized questions about breast cancer in a conversational format, which is tailored to their concerns. The Personalized Wellness Hub creates personalized plans by taking into account key personal details such as age, gender, dietary preferences or restrictions, and current activity levels. It offers guidance in 3 aspects, which is nutrition, exercise, and mind and wellness. Coming to the nutrition and meal plan, it's a in the Personalized Wellness Hub. It provides a tailored dietary guidance, nutritional details, and caloric information. The exercise and mobility plan includes adaptive fitness strategies, structured exercise, and guidance and practical tips. Then we have the Mind and Wellness Plan, which includes emotional support tools, well-being practices, and social connection tips. Now, the third option of the Navigator app is the tailored learning section, which offers access to comprehensive educational resources based on four main topics. These topics are types of cancer treatments, patient and survivor journey mapping, managing post-chemotherapy, and post-radiation symptoms. The types of cancer treatment section provides treatment options for 5 treatments from surgery to immunotherapy. This section includes resources on emotional and physical challenges, post-treatment follow-up, survivorship and rehabilitation, and long-term care. The Managing Post-Chemotherapy Symptoms section includes resources for managing an array of side effects from nausea to gastrointestinal symptoms. This section also includes resources for managing 6 symptoms following radiation therapy.
The main design used a flow diagram for consort flow diagram for implementation science. At the enrollment phase, we had sent out invitations and then screened and recruited people. So screening for eligible participants with newly diagnosed breast cancer in the inclusion criteria and tracking the contact information via master data sheet. So we had eligible and informed consent from 148 people, and people who completed the baseline was 138. Ineligible and excluded people were 20. At the assessment and randomized phase, we had 138 people who were allocated randomized to digital health innovations, 69 people, and standards of care control, 69 people. The participants in the digital health innovations group were allocated to psychosocial and education webinars, coordinated telephone support service, and community-based cancer care resources. They received a mobile-based application, open education resource, and the web-based education. People who did not receive the treatment or declined were 10. Follow-up assessment at 3 months included 54 people in the intervention group and 54 people in the control standards of care. At the end, we analyzed 54 people in the intervention group and 54 participants in the control group. A basic look at the overview of the demographic characteristics showed that we had 31.48% of people who were in the age group 40 to 49 years in the intervention group, compared to 22.2 people in the control group. We had 90.74 people percentage who were female in the intervention group, compared to 92.69% in the control group. Among the race and ethnicity, we had 48.15% of people who were Caucasians in the intervention group, and 20.37% who were indigenous, 16.6% black, 14.81% who were Asian or minority ethnic. 33.33% of the people had a basic college, associate or technical degree, compared to 37.04% of people in the control group. Looking at the usability, feasibility, satisfaction, and acceptability of professional navigators in the research study, among 54 people in the intervention group, 48.1% of the people said they were able to connect with the professional navigation without difficulty. 42.6% of the people said they were able to meet with the research coordinator. 42.6% of the participants said that this navigation app helped them to build their self-satisfaction. And 40.7% of the participants reported contribution to their personal well-being, ability to do it again, and ability to recommend it to someone else. Looking at the functional assessment of cancer therapy, specifically on the breast cancer scores, from baseline to post 3 months and post 6 months, there was a change in the score. And if we can look at the emotional well-being domain, there was an increase in the mean from 20 to 19 to 21.9 in the intervention group. and that was statistically significant with the control group who were at 13, 16.8, and 17.7. Similarly, emotional and family well-being was highest, 23.2, in the intervention group compared to the control group, and was statistically significant and increased by 6 months from 24.7 and 22.3 respectively in the intervention and control group. The breast cancer subscale showed there was an increase in mean from 22.7 to 25.6 in the intervention group compared to the control group, and was statistically significant at P at 0.01 in the 3 months and the 6 months.
So these are the qualitative key findings that have emerged from the study. These findings include 6 themes, which are number 1, mentorship and peer support, navigation, continuity of care, and patient advocacy, impact on identity and interpersonal relationships, quality of life concerns, psychosocial and financial burdens, and access to tailored educational resources. These are a few significant participant quotes that we have chosen to show in the presentation today. So for the first theme, which is mentorship and peer support, participants mention the need to find peer mentors and structured mentorship on psychosocial issues such as body dysmorphia. And in theme 2, participants found value in receiving support through patient advocates. One participant specifically mentioned the need of an indigenous patient navigator. There is also a need to strengthen navigation and continuity of care among healthcare providers. Participants also want structured educational resources they can rely on, cater to their psychosocial needs. The structured educational resources would help them make informed decisions throughout their cancer journey. Another key theme is psychosocial and financial burdens, where participants worried about the recurrence of their disease. Financial burdens include expensive parking, long distance travel, lodging expenses, and missed work. Findings show that there is an impact on identity and interpersonal relationships. Patients feel isolated and are unable to share their feelings with their loved ones. Lastly, one's overall quality of life is affected due to cancer, due to aggressive chemo and radiation treatments, multiple surgeries, infections, treatment side effects to various parts of their body.
The study, looking back at the implementation evaluation, the outer setting showed that, referring to our local environment here, which included health policy, the inner setting that we looked at identified the lack of time with follow-up appointments, the navigation through digital health, and the person invested in their own survivorship journey to learn about the knowledge that they need to take to strengthen themselves with different resources, programs, and services in the community about survivorship. And the workflow, looking at back at professional navigators, has a lack of time, has a significant barrier connecting with participants, and participant characteristics that showed that some of the themes from the qualitative study, that the need for people who are diagnosed with breast cancer about finding out accurate information needs for their symptomatic and long-term management with treatment, and the engagement of themselves in their care, and the availability of resources in different languages other than English, and the intervention characteristics that showed that there was a lack of individualization and a perceived lack of benefits of the interventions were some barriers in the rural communities. 54% of the participants completed the digital health intervention, demonstrating a higher perceived confidence and knowledge following the participation. And participants highlighted the utility of resources and cultural training in enhancing survivorship care. Looking at survivorship care detailing in our digital health innovations, one is to consider from the discussion is the survivor's needs and preferences in their early phase. And the second part was focusing on their survivorship in the setting that they belong to after receiving the active cancer treatment, that led to an ineffective survivorship care. And the third was looking for digital health innovative tools that could be a complement to them in their survivorship journey. Some of the discussion findings highlight that feasibility revealed a strongly positive motivation for participants' accessibility to digital health tools and also a logically accepted method for reporting these symptoms. The proportion of participants who reported that digital health tools helped them was one main phase was on remembering their symptoms was stable along the time in their whole cancer care journey, other than the side effects that they have faced during the treatment. All of them reported a satisfaction information reflecting satisfaction with the use of digital health tools, especially delivered by professional navigators. Professional navigators also reported the use of digital health apps to be a little bit user friendly for them, right where they are facing the care with the participant. Focusing on digital health interventions was a way to leverage the support with the family and community, turned out to be the highest satisfaction that the participants faced. They also reported that accessible, user friendly digital materials were clear, purposeful, and content rich graphics helped them in their journey. Enhancing the participant engagement in their own navigation and in their own survivorship with the help of professional navigators was one of the key findings of the study. Participants mentioned the need for mentorship, which would help them to receive emotional help and survivorship and practical support. Compared to other previous research that discusses how mentorship programs can help patients to find purpose in them living and make sense of their lived experience, which transformed an uncertainty into something constructive and affirming by Pappeldoer in 2016. There was a need for effective coordination among healthcare professionals, a very proactive approach by general practitioners and communication with the treatment team to streamline the care and coordination of care of people in the community by Sperson in 2024. Our study also showed structured educational resources early in the cancer journey can help participants develop healthy habits, build resilience, and make informed treatment decisions with greater confidence. Participants in our study also mentioned the need for higher education about treatment options, since structured education support will allow them to make decisions about their confidence. Another study by Smith in 2019 discussed that breast cancer treatment affects a woman's body image, at the same time their identity significantly, and it threatens a woman's self-image, body image, and femininity. In our study, participants experienced a loss of personal identity and independence due to cancer as a treatment that limited their ability to engage in meaningful activities. There was also showing from the study that emotional and physical burden and the distress of it both on them, their family, their friends who could provide the caregiving support. There was also a huge emotional and psychological toll. Cancer, particularly surrounding the body image, intimacy, and sexuality. The individuals explained a lack of dialogue around the impact of breast cancer treatments on intimacy and sexuality, leaving participants without guidance on managing these challenges. We conducted a knowledge translation in 2024 based on the research studies with our collaborators, partners, the community, and lived people who lived the experience. So one of the part of our knowledge translation summit in 2024 was collaborating with healthcare practitioners. So this collaboration showed the main domains of care in practice to create priorities in survivorship, engaging with the community with respective needs, especially population in the rural. And what are these special considerations for minority populations in rural communities of British Columbia? The second part was looking at policy advocacy initiatives. And one of the themes that came out was creating a position statement on advocating for policies that address the very specific needs of the community and working together with policymakers to enact on research, focusing on distress screening and management. The third aspect of this summit was a person-centered survivorship model that was created for creating a community integration, coordination of care, and navigators network. Learning from what healthcare providers are already implementing in their disciplines and applying best practices to broaden and strengthen the model of care in rural communities. And the fourth was creating continuous community engagement forums, educating on cultural appropriate interventions, organizing the community workshops and support groups is a great way of a stepping stone to apply evidence-based practices to improve the quality of life of people and promote awareness and education about cancer services in the rural communities. Early this year, we conducted a World Cafe in 2025, and that created a joint collaborative community research hub in rural region here in British Columbia. With this, we created a joint collaborative research hub initiative between the community and the university, focusing on cutting-edge, groundbreaking novel technologies and implementation science approach. The second part of this World Cafe came out as a support group and digital health innovations. We established a support group and resource specially tailored for people affected with cancer, including adolescents, young adults, aging, seniors, Black, Asian, and minority ethnic, rural, and remote populations. The third part was an informative community engagement forum, which included implementing workshops, awareness sessions, education outreach, events on campus, and optimizing survivorship care resources, organizing regular engagement forums to facilitate knowledge exchange and sharing best practices between the healthcare providers, researchers, community partners, and lived experience. And the final was utilizing multimedia channels for promoting health promotion messages. So we utilized various multimedia channels like radio, television, internet to raise the informed awareness and disseminate culturally appropriate health information messages. At the end of it, the main themes that came out from the knowledge translation was looking at predicting and preventing cancer, looking at metastasis and palliative, what was the meaning in the people, and looking at culture, living and thriving with survivorship. And some of the findings from the studies are ongoing and creating a cancer navigation center for supportive care in the rural communities in British Columbia. The implications from this research study was identifying barriers and facilitators that can guide further implementation strategies to expand survivorship care programs and policies, introducing formal professional and peer mentorship with people who are newly diagnosed are paired with professionals and care survivors who would be helpful to thrive and reduce emotional distress, introducing professional navigators who assist with appointment scheduling, accessing the resources, and providing information about available resources would help to reduce the emotional distress in individuals. Digital health innovations represented a very safe, culturally informed, responsive approach to addressing disparities in cancer survivorship model in rural communities. And an integration and blend with virtual health appointments can help to reduce the burden of travel and allow for more flexible scheduling, making it easier for people to sustain survivorship in their journey. Some of the conclusions from our study was a need for a person-centered integrated approach to cancer care and multidisciplinary approach to cancer care that includes professional navigators improving reported outcomes. The second was building on the existing capacities, skills, knowledge, and confidence among healthcare professionals and people to reduce inequities and improve survivorship experiences for diverse rural and remote communities, and improving on digital health interventions that show strong acceptability and uptake for enhancing supportive and early survivorship care among diverse populations in rural communities, and utilization of digital health innovations that is focused on developing the knowledge and skills for increasing motivation and maintaining a long-term commitment with their care, and the efficiency of professional navigation with symptom tracking to mobile, web-based and virtual health digital tools to create a very person-centered care pathway and survivorship model of care. These are some of the references for the current presentation. And the funding, we acknowledge Breast Cancer Canada and the Canadian Institute of Research, Planning and Dissemination. The lead presenters declare no conflict of interest. The funded grant was created mainly for research purposes by a team of researchers, community partners, and advisory board from British Columbia. And our partners and collaborators are BC Cancer, Thompson River University School of Nursing, the Thompson Rivers University, University of British Columbia, Population Health Aging Rural Research Center, Kamloops Cancer Supportive Care Society, the Inspire Health Supportive Cancer Care, Interior Health, Canadian Mental Health Association, the Immigrant Services and Refugee Services, Spirit Warriors, and Kamloops Breast Cancer Support Group. So thank you very much for this presentation, and we are open to any questions that you would have from our research study.